So welcome everyone to our February Population Mental Health Forum. We are, before we get started, just a few Zoom things that I think folks are used to now. One is this is being recorded and the video will be posted on our website once it gets captioned. So that usually takes about a week. During the session, please put your questions using the Q&A feature and then we will give them to the speaker. Some resources may be shared in the chat, but if you could use the Q&A, that would be great. And other than that, let's get started. We are really lucky today to have Dr. Katherine Keyes, who's a professor of epidemiology at the Mailman School of Public Health at Columbia and a colleague and a friend. And we've all heard a lot about the current youth mental health crisis. The Surgeon General came out with a report the end of last year. And one of the people's work that I've really always go to kind of understand youth mental health is Dr. Keyes. And she'll talk today about cohort effects and adolescent mental health trends. So thank you so much, Carrie, for doing this today.
Sure. Thank you so much for the invitation and for having me here. What I'm going to do today is provide kind of a 10,000 foot view of what we know about current trends in adolescent mental health and how I and my colleagues have been approaching how to think about causes of the changing adolescent mental health trends from an epidemiological standpoint, how we're using data to try to really inform some of these discussions beyond speculation. So just to set the stage, there has always been a lot of discussion about trends in youth mental health. And for example, in the 90s and in the 2000s, there was a lot of concern about potential rising trends in youth mental health, especially as service utilization for conditions such as depression were increasing, especially among youth. And Jane Costello and colleagues did, I think, a really excellent meta-analysis that was published in 2006, reviewing 26 different studies in this kind of classic psych-epi framework, which is that, when you want to understand trends in the community, you can't rely on treated rates. Like, we can't rely on trends in who's using psychotropic medications, for example, for depression. You have to go out into the community and count cases beyond a physician's office. And what that meta-analysis found in 2006 was really that there was no evidence of an increase in prevalence of child or adolescent depression over the past 30 years, when you actually went out and really looked at community-based samples. So that was kind of, published in 2006. Most of the data that were used for that study were from the 80s, 90s, 2000s. But since that time, I think that there is an emerging signal that that really is changing. And some of the first hints that we got that, there were these increasing trends in youth mental health came from, various data sources, such as the National Survey of Drug Use and Health. And this paper that was published in 2016, which reviews data through 2014, you can see that major depressive episodes among adolescents in the National Survey on Drug Use and Health among both boys and girls were relatively stable from 2005 to about 2010, 2011. And particularly among girls, you started to see this increase in major depressive episodes. There's somewhat of an increase among boys, but it was really more concentrated in girls. So that was kind of one data point. And using Monitoring the Future data, which I'll give more detail on in a little bit, we also have been tracking trends in depressive affect and other kinds of youth mental health symptoms. And what we saw was really remarkably similar to what was seen in the National Survey on Drug Use and Health. These are data on 8th, 10th, and 12th grade adolescents from Monitoring the Future, which is nationally representative. And if you see among girls, there was actually, we go back to 1991, and what we saw was throughout the 90s and the 2000s, there was really declining mean depressive symptoms among adolescents. And then it really was this 2010, 2011 point where we started to see really rapid increases across all grades of girls, and less so among boys. The trends are relatively more stable among boys. And this study ended in 2016, but I can tell you that since 2016, the mean depressive symptoms have continued to increase, and we're now even seeing more increases in boys as well. Other data sources, again, point to a very similar story. These are data from YRBS, the Youth Risk Behavior Surveillance Study, looking at trends in suicidal behavior among adolescents, including the more prevalent suicidal ideation, making a plan for suicide, attempting suicide, and attempting suicide in an injurious way that required medical attention. And similarly to monitoring the future, there really were declines in these kind of prevalent suicidal behaviors, such as ideation and making a plan throughout the 90s and 2000s. And again, it's really this kind of 2010, 2011 point where we really start to see increases in these suicidal behavior symptoms. All of the studies that I've discussed so far are based on adolescent self-report. And so a common reaction to these data is, well, maybe youth are more open to discussing mental health problems or more able to report their mental health problems. There might be less stigma. But when you look at rates of hospitalized, trends in rates of hospitalization for intentional self-injury and suicide attempts, you see the same pattern. These are data from HCUP, the Healthcare Utilization Project. And this bottom line here is the trends in all pediatric emergency department visits. And you can see that for all pediatric emergency department visits, there's really no trend over time. But when you look at pediatric emergency department visits for intentional self-injury and suicide attempts, you really start to see increases really about the same time of 2010, 2011 is when it starts increasing. And unfortunately, we're seeing the same trends in fatal suicide as well. These are trends in suicide death rates for adolescents aged 15 to 19. The axes are different here, so just note that. Males are more likely to die by suicide than females in the United States. But really, you see this kind of same pattern that right around 2010, 2011, and particularly concentrated among female adolescents, you start to see these increases. And you're seeing, again, increases in males too. Those increases are happening slightly later than for girls, but we're seeing increases in both. So across a number of different data sets, we're seeing really converging evidence that adolescent mental health problems are deteriorating, and that we've seen from major depressive episodes, depressive symptoms, self-injury, intentional self-injury, and fatal suicide, all converging right around that same time point. So, the epidemiological question, of course, is why? And more fundamentally to the work that I do, how do we think about how to answer those problems? We can all come up with speculations about why this is occurring, why that time, but what do we need to see in the data in order to, really confirm or refute various hypotheses? And really what we would need to see is to explain the increases, potential causes of the increase should be related to mental health problems, right? We need to see an association between this putative exposure or risk factor and the mental health problems that we observe in the data. And then secondly, whatever that risk factor is should be increasing over time, in the same degree and similarity as we're seeing with the increases in mental health problems. Or you could, also observe that even if the prevalence isn't increasing across time, the strength of the relationship between a risk factor and mental health problems should be strengthening over time if it's explaining the increase in mental health problems. So in our work that we've done, and I'll present several of the studies that we recently conducted, and a lot of this work is ongoing. So one of the reasons I'm presenting this today is really to get feedback. I mean, truly get feedback from people who are here today, because, a lot of this work is continuously in formation. But some of the things that we've looked at, and this is only a small portion because they didn't give me, all day long to present all of our work. So I'm just going to focus on a few specific risk factors that we've looked at. One is cyberbullying and other forms of bullying. Smartphones, there's been a lot of discussion about smartphones and social media as drivers of adolescent mental health problems. I'm going to talk about loss of connection and community and the centrality of religion, and also factors such as hypersurveillance. I'm going to talk about two of the main data sets that we've used to do some of this work. The work that we've done is not limited to these two data sets, but I'm really going to focus on these two. So I'll just give you a little bit of background on them. And I've already talked about them in introducing kind of the motivation for this work, but I've been involved for many years in a study called Monitoring the Future. This is a yearly, annually conducted nationally representative survey of 8th, 10th, and 12th grade adolescents in the United States. We sample about 45,000 students per year. And the study started in 1976 for the 12th graders, and then 8th and 10th graders were added in 1991. So we can get a really long time series for a lot of both the risk factors and the mental health outcomes that we're interested in studying. And I'll just note, I'll talk about a little bit about the young adult data, but in Monitoring the Future, each 12th grade cohort is then followed longitudinally after they graduate from high school. So we have data now on the Monitoring the Future participants since 1976. So we're doing age 55 and age 60 surveys of the Monitoring the Future participants. I'm also going to talk about data from the YRBS. This is biannually conducted, so every 2 years, nationally representative. It's conducted in schools, and about 15,000 students per year in grades 9 through 12 are sampled as part of the YRBS, and it was started in 1991. So I'll start by talking about online and offline bullying, because that is often brought up as a potential risk factor to explain these increasing trends. You know, teens are more online, and with more online connections, there can be more anonymity and more bullying that takes place. What we've seen in YRBS is that there's really no time trend with respect to online and offline bullying, at least in recent years. They started measuring online and offline bullying in 2011. So shown here is the prevalence of offline bullying in blue, offline bullying only, so adolescents who are only bullied offline, and then green is adolescents who are bullied only online, and then red is adolescents who are bullied both online and offline. And there's some indication of an increase, but really the prevalence has been remarkably stable for both online and offline bullying across time. So not changing in, not rapidly increasing in ways that would be predictive of the trends that we're seeing in adolescent mental health problems. What is true, though, is that online and offline bullying remain really critical risk factors for suicidal behavior in adolescents. When I talked about how we not only look at the trends in these things, but also if the relationship between the putative risk factors and mental health problems are changing over time. We did that in this analysis. And if you look across each biannual survey of YRBS, what you see is that being bullied remains a really critical risk factor for suicidal behavior. The odds ratios for example, being bullied both online and offline are remarkably large, and 4 to 6 times more likely to engage in suicidal behavior given online bullying. And these are really socially patterned. So kids who are marginalized, we've seen, big disparities in experiences of bullying by race, by sex, by sexual orientation status. So these really still are very critical risk factors to consider among adolescents. The relationship between online bullying and offline bullying has been really stable across time. If you look at, these are p-values for the interaction between year and victimization, and the strength of the association is not changing across time, which is really bad news, because we know that bullying is this major risk factor for suicidal behavior among adolescents. And there has been, a lot of emphasis on reducing exposure to bullying among adolescents, but we've seen neither change in the prevalence nor change in its risk factor association with mental health outcomes. So I think still a really critical risk factor that we need to consider, but doesn't seem to be explaining the major increases that we're seeing in mental health problems. I'll go now to the centrality of religion. That's also often brought up as well. And here we do see some real signals that there are declines in the centrality of religion to adolescents' lives and in their religious service attendance. Shown here on the right axis is that mean depressive symptom, and you can symptom score, and you can see those increases starting in 2010 and 2011. And on the right axis, we graphed the percent of students who attend religious services at least monthly, and the percent of students who feel religion is personally important to them. And here there have been major declines across all adolescent groups in terms of that centrality of religion. And I don't show it here, but religion is a protective risk factor for adolescent mental health problems for adolescents who say that religion is central to their lives. For those adolescents, there is a protective association. So we wanted to see how much that change in centrality of religion over time explained the trends in mental health symptoms that we saw. So what we did was a kind of simulation or a projection analysis. So shown here in blue is the observed mean depressive symptom score among adolescents. You can see that big change right around 2010, 2011. So that's our observed symptom score. In red, what we did was we set the prevalence and the distribution of religious centrality to adolescents' lives to its 1991 distribution. So we froze in time the distribution of centrality of religion in the Monitoring the Future data, and then we projected what the depressive symptom score would have been across time if religious centrality had stayed at its 1991 levels. And so that's what's shown in red here. And you can see that there would not have been as big of an increase in depressive symptom scores if the centrality of religion had stayed at its 1991 levels. But it certainly doesn't explain all of the increase. Proportionately, it explains about 28% of the increase. So a little over of the quarter of the increase in depressive symptoms is explained by declines in religious centrality. And that's not to suggest that, the intervention here is to make people more religious, but that there are components of that sense of self, the sense of meaning, the sense of connection with the world, and the social connections that come with religious service attendance and religious centrality. And so thinking about how we can replicate those senses of connections among adolescents, especially marginalized adolescents, I think is really the key takeaway from that. So moving on to smartphones, this has been a huge topic in the literature. And every single time I present this work, before I even get to this point, people say like, it's the smartphones, we've got to take the smartphones away from the children. And there's been a lot of, punditry around smartphones. Jean Twenge, for example, wrote this influential article in The Atlantic in 2007. Stating, have smartphones destroyed a generation, that adolescents are disconnected, that, they're not spending as much face-to-face time with other peers, that there are mental health consequences to, peer comparison and other sort of dangers of being on social media. And there's some evidence to that as well. There's been a lot of sort of correlational studies, I guess. So this is hours of screen time per day in the UK, showing that, there's kind of this reverse J-shaped curve where, a little bit of hours of screen time per day is associated with increased mental health and well-being. And then there are declines thereafter with each increasing hour per day on screen time. And there's been this is one of many studies that kind of show a similar association of this decline in mental health with increasing amount of time spent on screens. But a really interesting analysis, I think, that was conducted and published in 2019 led a lot of people to think differently about these kind of crude metrics of the amount of time spent on screens. So this is Amy Orban and Bill Shabilsky published this paper where they did a specification curve analysis. And essentially what they did was to say, okay, look, there are many different decision points that one can make in doing an epidemiological analysis. You could look at your outcome as continuous. You could dichotomize it. You can look at different regression distributions. There are many different ways to categorize your exposure similarly. Like, do you look at screen time hours per day as a continuous variable? What screens count? Do you include TV time? Do you include internet? Do you include social media? There's all these decision points that we can make in an analysis. And what they did was in the specification curve analysis, and these are data from Monitoring the Future, they did thousands of regressions with every single specification that you could imagine for your outcome distribution, for your exposure distribution, for your covariate distribution, which covariates you include, which covariates you exclude. And then they graphed all of the beta coefficients for all of those thousands of regressions from smallest to largest. And shown in black were sort of statistically significant associations. So basically, what they found was that depending on how you categorize exposure and outcome and covariate, you could, using the same data set, conclude that there is a significant negative association between screen time and mental health. You could conclude that there's a significant positive association between screen time and mental health. And shown here in red is kind of no significant association between screen time and mental health. So really, depending on how you categorize the data, you could generate any conclusion that you want to. And when you take the mean of all of those different betas from all of those different specifications, you get this dotted line here. So among the many, many different decision points we could make, the mean of those would include a slightly negative association between increased screen time and decreased mental health. What they also did in that paper, which I think is really important for all of us to consider when we're thinking about risk factors for adolescent mental health, is that they compared then that negative association with the size of other risk factors that we know to be consequential for adolescent mental health. So in the same data set, Monitoring the Future, for example, the association between binge drinking and mental health problems is 8 times larger than the association between screen time and mental health problems. The association between marijuana use is 10 times larger, getting into fights is more than 15 times larger, smoking cigarettes is more than 18 times larger. And then going down to like positive factors, for example, eating fruit is 9 times more beneficial for your mental health than screen time, eating vegetables, getting sleep, eating breakfast, so all of these things are, kind of the known risk factors for adolescent mental health, both negative and positive. And basically what they showed was that if you, in the YRBS data, for example, the associations that have a similar magnitude that we see for screen time and social media, eating potatoes and perceiving your weight and asthma and drinking milk are approximately similar in terms of their association with adolescent mental health problems. In our own work in Monitoring the Future, looking across 2009 to 2017, when we look at going on social media every day, daily social media use, and association with depressive symptoms, what we decided to do was to divide the Monitoring the Future sample into depression propensity scores. So we used all the data in Monitoring the Future to estimate propensity for high depressive symptoms among adolescents based on known risk factors, including substance use, including, all kinds of adolescent risk behaviors. And so, teens have either a low depression propensity or a high depression propensity. And then we estimated the association between using social media every day and depressive symptoms within those depression propensity groups. And essentially what we found, shown the boxes here that are highlighted in orange are where we saw a real signal of an association. And for girls, there was a signal of an association between daily social media use and high depressive symptoms, but it was really only, we really only could see it among the girls who had the lowest overall propensity for having a high depressive symptom score. So these were adolescents who really had no other risk factors for having high depressive symptoms. And so for those groups, there was an association between using social media every day and high depressive symptoms. A similar story for boys. It was really in these groups with low depressive propensity where a signal emerges for daily social media use. But curiously for boys overall, there was a protective association. If you look at the group of boys together, those who are going on social media every day had lower probability of having a high depressive symptom score. So certainly not a consistent association or, an association that really affected the group of teens that are likely to experience clinically significant depression. It was really kind of these teens who have a very low prevalence of depression overall. We also tried to do a similar approach in the YRBS in a paper that I was involved with Adam Leventhal and his group at USC. And here what we did was, kind of exactly what I was describing earlier, like you really have to see, is it associated with the outcome? Isn't it changing in a similar way as the outcome? Here we saw that, for example, for here we're looking at suicidal behaviors as the outcome. And we see here, this is the association between year and suicidal behaviors. And so you can see overall that suicidal behaviors are increasing across time among the YRBS adolescents. And we also can see that that social media use is increasing across time. This is the association of year with digital media use. These are odds ratios, these are betas, but you can see with the betas, they're going up over time. So teens are using more social media and they're more likely to have suicidal behavior. However, the association between digital media use, just like we saw in Monitoring the Future, just like Orban and Chabilsky were able to demonstrate, there's a pretty weak association between overall using digital media and suicidal behavior. The odds ratio for any suicidal behavior was 1.1, and you can see that for specific suicidal behaviors, it's 1.11 or lower. So what we tried to do is like a mediation analysis, like, okay, given that there is like some association here, how much of the yearly trend in suicidal behaviors maximally can digital media use explain? Because of course there could be confounding factors. And in this paper, we controlled for a lot of different confounding factors, but it's observational data. There's, many uncontrolled confounding factors that we couldn't control for. But we said, all right, at its kind of maximum, like if we just assume that, all of this mediation is occurring through digital media use and there's no kind of, XM confounding, what proportion could maximally be mediated by digital media use? And that's what's circled here in red. And it's not very much, it's about a quarter to, getting to about 40% of the total effects of year on suicidal behavior could be maximally explained by digital media use in these data. And that has contributed to a lot of other meta-analyses and reviews of this association between digital media use, social media use, online life, and adolescent mental health. And this is a review that was published in 2020, led by Candace Odgers, who's really an expert in this area, which concluded that there's really not any evidence that there's a clinically meaningful detectable effect of social media and smartphone use on adolescent mental health if you look really deeply at the studies. When you're using this kind of broad category of like amount of time spent on social media and kind of broad metrics like that. And that then led to media coverage, panicking about your kids' phones. New research says don't, so that like just kind of this overall concern. And like, I'm a parent, like I'm concerned about it. You see a kid just staring on a screen all the time. But, the data that we have so far suggests that at least the amount of time that teens are spending on social media is not driving the increases in depressive symptoms and suicidal behavior that we're seeing in the US population. We've now tried to kind of come up with different ways to I think a critical question is like, maybe it's not how much time, but what are teens looking at? What information are they taking in? And, for particularly high risk teens who may be going online already with mental health problems, are there particular patterns of use that we should be concerned about? And so just one example of that, of the work that we're doing is shown here. We looked at adolescents' political affiliations, whether adolescents identify as conservative or liberal in the Monitoring the Future data. And really what we saw was that the biggest increases in mental health problems that we've seen among US adolescents are really concentrated among female adolescents who identify as liberal. That's where we're seeing the biggest increases. Female adolescents who identify as conservative are increasing as well, but the increases in female conservatives started much later, and the increase isn't as stark as it is for liberal female adolescents. And that suggests that there may be kind of a polarized online environment, and that adolescents who feel marginalized by the broader system may be being exposed to a more fractured media environment, may be exposed to more hate online that might be driving some of the increases that we're seeing in mental health problems. And really what that led us to think about more generally is kind of, trying to be a little bit more comprehensive about our assessments of teens' lives, adolescents' lives in the US right now, and how it's shifting in so many different ways that if we start abstracting these like single risk factors, we're not really able to observe the entirety of the adolescent experience. And as just one example of that, what we've seen is that if you look at an indicator like just going out in the evening unsupervised without your parents, that's rapidly declining as well. These are data from Monitoring the Future. On the left is boys, on the right is girls for 8th, 10th, and 12th graders. And you can see for girls, for example, the number of evenings out per week by grade from 1991 through 2015, again, was relatively stable throughout the 90s and the 2000s, and it's really started to rapidly decline after 2010 in terms of that unsupervised time with peers. And that really led us to think about all the different ways that adolescents spend time. And so we went to Monitoring the Future and we pulled out all the items that related to different activities that adolescents do. Dating, going to parties, going out without your parents, spending time after school alone, driving around in a car for fun, which like I did all the time as an adolescent. Sounds now like, why were you driving around in a car? But that's really fun when you're an adolescent. Going on social media, visiting your friends, being engaged in your community through things like sports, the religious service attendance, those types of variables that we've been working with, working in your community, doing community service or volunteer work, spending time at video arcades, so we really tried to like get all of these different indicators together. And we did a latent class analysis to try to see if we could come up with groups of adolescents who engage in various types of activities. And we, among our research group, would call it like the Breakfast Club analysis, because like when you do a latent class analysis of adolescents and the times they spend together, you kind of get like kids who play a lot of sports, kids who go to a lot of parties but don't engage in a lot of academics, kids who study a lot. You kind of get your like John Hughes groups extracted from that latent class analysis. So we did that, and then we looked at the prevalence of being in each of those classes over time. And what we found was really stark. So for example, in the 1990s, the group that was most prevalent was groups that were highly social, going to parties, going on dates, driving around in a car for fun, and highly engaged. They were participating in sports, they were participating in community service work, they were participating in their religious communities. And really the prevalence of that group, well, it was 40% or higher in the 1990s and 2000s, it's rapidly declined in the past 10 years, so that now it's declined by almost half by 2019 of kids who are members of that particular latent class group. And what's taken their place is really two groups, this kind of medium social group. So these are kids who are engaging in some kind of activities, but to a less extent as the high social group, and this low social group, the kids who are not really engaged in a lot of activities, a lot of unsupervised time with friends, either organized or unorganized. And so kind of this nature of time use is fundamentally shifting among adolescents, I think, in ways that have really profound implications for like the meaning of adolescence and what adolescents are doing now. And if we then look at how each of these groups contributes to the overall burden of depressive symptoms in Monitoring the Future. Starting in 1990, you can see that, there was a relatively even distribution across these groups. Kids who are low social typically have higher prevalence of mental health problems than kids who are highly engaged. But these distributions are fundamentally shifting so that by 2019, this medium social group, that group that's really growing in prevalence, is bearing the brunt of the highest burden of mental health problems in terms of the amount of mental health problems that are being experienced by that group versus other groups. And this highly social group is declining in terms of how much of the distribution of mental health problems are being contributed to by that group. So not only are the group prevalences are changing, but then even though the low social group, for example, are at the highest risk for mental health problems, these other groups are, because they're increasing in prevalence, are increasingly explaining the distributions in mental health problems that we're seeing. Importantly, we saw increases in mental health problems across all of the groups. All 6 groups had increasing mental health problems, but because there's shifting distributions and prevalence of all of these groups, some of them are now taking on much more of the variance in terms of mental health symptoms that we're seeing. So I just want to, and I'm really curious to hear what other people think about that and other directions that we can go with that as well. And I wanted to obviously close, talking about this by talking about COVID. There's been a lot, of discussion about mental health problems during the pandemic and how the pandemic has affected adolescents. And there have been numerous now meta-analyses and systematic reviews of depression and anxiety symptoms among adolescents during COVID-19. And these analyses suggest that there is a big burden of mental health problems among adolescents during COVID-19, and upwards of 30 to 40% of adolescents are experiencing depressive and anxious symptoms during the pandemic. However, as we've shown here, there have been increases in mental health problems going on for the last 10 years. And if you look at how much of the increase is, a deviation from that long-term trend, it's not as significant as I think you might think if you hadn't been studying mental health problems among US adolescents for the last 10 years. 30 to 40% of adolescents experiencing mental health problems is not outside of what we have now been seeing, especially in the last few years pre-pandemic, in terms of the growing mental health crisis. So that's not to say that there isn't a mental health crisis during COVID. There absolutely is, but it's an acceleration and a reflection of these long-term trends that we've already been seeing. Suicide rates, I think, are a really important part of that discussion. These are provisional data from the Vital Statistics, National Vital Statistics Surveillance System, and that Tyler Black has recently put out. And if you look month by month at fatal suicide among US adolescents. Shown here in blue is the trend in fatal suicide during sort of the March to June months in 2018 and 2020. And 2020 to 2021, that first pandemic year, suicide rates were actually significantly lower than we saw in previous years. And in fact, we've never seen suicide rates among US adolescents that have approached their kind of summer rates, the outside of school rates, where typically we see lower rates of suicide among US adolescents. Now when we look at the September to February trends, there is kind of a rebound. We're seeing increases in fatal suicide among US adolescents, but not significantly different than what we saw from 2018 to 2020, but still some hint of concern among US adolescents. Our own data that we have been working on, so we did a COVID-19 supplement for our 12th graders after the pandemic started, in the summer after the pandemic started, to ask, about COVID experiences and mental health problems, and try to do our own research on this. And this is led by Noah Kresge. And what we did was we had the PHQ-9, which I think probably a lot of people are familiar with, and an anxiety symptom scale. And we asked adolescents, how often in the last 2 weeks they were experiencing each of these symptoms, and whether or not they attributed that symptom to pandemic-related experiences. And so this is, each of these pie charts is the proportion for each of these symptoms. So this is little interest or pleasure in doing things. And you can see that, over half of our young adult sample in monitoring the future in this survey reported having little interest in or pleasure in doing things. But modally, though most of adolescents didn't attribute it to the pandemic. And you can see that across these other, symptoms as well: feeling down or depressed, trouble falling asleep, feeling tired, poor appetite, feeling bad about yourself, trouble concentrating. These are symptoms that are really affecting the lives of adolescents and young adults. They have extremely high prevalence. And at least the adolescent's own attribution of whether those symptoms are related to COVID-19 is not insignificant, between 17 and 20% for some of these symptoms, going down to less than 10% for other symptoms. Teens are attributing it to the COVID-19 pandemic, but the majority of adolescents who are experiencing those symptoms there are lots of other things that are going on in adolescents' lives, and there always have been, especially in the last 10 years, that are additionally contributing to these mental health problems. And we saw a similar story for anxiety symptoms, that the majority of the adolescents in our sample were experiencing clinically significant anxiety symptoms, and a minority of those kids were attributing those symptoms to COVID, but not zero. You know, there's certainly a burden of mental health problems that is accelerated by pandemic-related exposures. And so we looked at that. We looked at pandemic-related experiences and whether they were associated with having, you know, above the clinical cutoff for these different scales. And we looked at whether they had clinically high symptoms that were not or somewhat attributed to the pandemic versus clinically high symptoms that were more than somewhat attributed to the pandemic. And so we looked at things like dropping any classes or changes to student status, changes to educational plans, lacking a place to sleep or money for rent, gas, or food, and a significant impact on employment. And across these different symptom scales, we did see associations, especially for adolescents who attributed their symptoms more than somewhat to the pandemic. We saw significant associations with each of these pandemic-related symptoms. And where we saw the biggest signal was lacking a place to sleep, for money or money for gas, rent, gas, or food due to COVID-19. Those adolescents were more than 4 times as likely to report clinically significant depressive and anxiety. They were four times more likely to report clinically significant depressive symptoms and 3.7 times more likely to report clinically significant anxiety symptoms, suggesting that it's, you know, kind of these social safety nets that we know have been fractured, again, since before the pandemic, that are really contributing to the acceleration of mental health problems that we're seeing in adolescents. So I will close there. I guess, you know, I'd be curious to hear what other people's conclusions are as we continue to conduct this work. But, you know, my conclusions at this point are that, you know, this is a really complex topic, and explaining what's increasing adolescent mental health problems is not going to be simple, and it's not going to be a single risk factor. We really have to look holistically at how adolescents' lives are changing. But what is really clear is that there is a crisis of adolescent mental health problems. It's been going on for 10 years. And we need direct and urgent action to take it seriously. And what we've seen across these studies is that, you know, it's really marginalized groups who have been experiencing the brunt of socially patterned risk factors for a long time, you know, and especially things around housing and food insecurity that really are driving a lot of what we're seeing in terms of disparities and in terms of who's bearing the brunt of these increases in adolescent problems. You know, I think more generally, adolescents today are facing a really uncertain future. There's political fractioning that's occurring, and they're seeing violence in their schools and violence in the world. And that's no more apparent than the political climate we've all been witnessing. And especially these adolescents who have a minority social status in terms of race, class, sexual orientation are particularly targeted, and the increases in mental health problems that we've been seeing are particularly concentrated among those students. Shown here is a picture of the Parkland, Florida teens and the rage and anger that they felt after their school shooting in 2018. And that really contributed to this growing cacophony of pleas from our adolescents to listen to them and to take their concerns really seriously about how they want to reshape the world. And you know, the experiences that they're having go much deeper, I think, than the pandemic-related stressors that adolescents are experiencing, and sort of simple solutions like smartphones. And I would just close by saying we owe it to this generation. We owe it to them to like focus our scholarship on listening to them and listening to their concerns and their needs, and thinking deeply about the broader social environment that we are exposing children and adolescents to, and how we can embed our own research in improving their environments through our scientific investigation. So I just want to acknowledge my funding. I especially want to acknowledge Noah Kresge, who was the lead author of a lot of this work and who is a fantastic scholar, as well as the rest of my research team, all who contribute to this work, and the NIH for funding it all, as well as my department. Thanks.
Wow, thanks, Carrie. That was pretty mind-blowing. I wish we had you for like 4 hours. I'm gonna have to fly to New York, and because I have so many questions, and there are so many questions. And as you know, I have a 14-year-old son and a niece who's 16 I'm very close to. So I feel very embedded in this whole, I'm living it, as well as following it and doing a little research on it myself. And what I was so wowed by was how you always approach the questions with, by looking at the data and figuring out how we can answer them in the data rather than just, coming up with our own, it's all the smartphone, it's all the, and I'm reminded of when my mom will say when she was a teenager, everyone attributed to adolescent problems to television and Elvis, like Elvis was destroying. And so it's sort of, it's easy to come up with these easy solutions. So there's so many questions, and I have questions too, but so Archana had a question. She asked, are there data to test the potential impact of other macrosocial determinants on youth mental health, such as the climate crisis? And then I'll just add the other question she had, which I also had, which is, do you have any sense of global trends? And are there places where we're not seeing this rise, where there maybe we can learn from that might be doing better with their adolescents? And I actually don't even know if the data really exists to answer that, but.
Yeah, I mean, and I can speak to what I know, but I'm sure there's probably other people who are like here who can speak to other countries much better than me. In terms of climate change, that's something we're really interested in investigating. We're doing a number of studies right now in monitoring the future on, we have these questions we've been asking in monitoring the future since 1976 that are like, I don't think I'm going to live to see adulthood, like pretty fatalistic questions about the world. And so we've been like kind of tracking those trends over time to try to just at least start to get at that question of how climate anxiety is affecting teens. We're also doing additional work to more directly try to assess the impact of rising temperatures on adolescent mental health. We know that in meta-analyses, about a 1% increase in temperature is associated with an increase in suicide, an observable increase in suicide across the world. And so, as temperatures are rising, we certainly anticipate that there are going to be increases in mental health problems due directly to climate change, and then more indirectly due to concerns about climate change. So we're doing a number of different studies collaborating with people in environmental health sciences here at Columbia to link cohort data to remote land sensing, temperature, and tree canopy data to try to assess that. I will say that it's incredibly socially patterned. Who's exposed to high temperatures that are not mitigated by natural or man-made cooling structures is very socially patterned in the US and in other places as well. So I think, the contribution of that to social inequalities is really something that we're going to need to study. In terms of what we've seen in other countries, I know the data I'm most familiar with are the UK and Australia, and I think that we're seeing similar increases in adolescent mental health problems there as well. I'm not as familiar with other countries, but I'm sure other people are.
Great, thank you. Thank you. I'm not aware of other country data either. There was a big, maybe I can find it, a big meta-analysis that UNICEF did of adolescent and youth mental health during COVID, which found similar things as you're reporting, but I don't know all the quality of all the research there. So a few people have asked about video games and the impact of online video games like Roblox and younger generations cohort, and and you got into this about different kinds of screen time, social media, video games, and people always ask about that. So any comments on video games or how we need to understand it?
Yes, I mean, so I'm most familiar with the work on like violent video games and whether violent video games increase aggression in teens, and it's pretty clear from the evidence that there's not. I would say it's kind of similar to social media in that teens who are at risk for experiencing problems related to video game use, their patterns of use are different, and they can get into a lot of trouble if they're exposed to high degrees of violent video games. I think that could be certainly a risk factor for some teens who have a higher propensity for adverse outcomes, but at a population level we don't really see an association violent video games were sort of the television and Elvis of like the
Right.
90s and the 2000s. So there's been a
Right.
ton of research on it with not a very, smoking gun conclusion. I don't know of any research that's looked particularly at, youth in the past few years with the rise of Roblox and Fortnite. And, as the parent of an 11-year-old, I'm like, yeah, I know they seem like terrible and I want to like ban them forever. But I don't know of any research that is specifically looking at these more modern games, except the research that's looking at kind of total time spent on screens, total time spent playing video games. And that really doesn't show an association with adverse mental health outcomes.
Right. Oh, that's interesting. Okay. A couple questions. Someone put the UNICEF report out there. If, well, so I know, so you have a, I guess a tween now, sort of close to a tween. And one of the things I'm sure you're aware of is that it's very hard to get kids into treatment. At least every person I would ever refer to in the Boston area has at least a 6-month. Most people have closed their waiting list. And even someone like me, who's like, quite well connected, it's almost impossible unless I get lucky. So what do you, so I've been thinking a lot about, obviously we need to increase access to treatment and all that. But beyond that, do you have ideas about both what parents, some people have asked what parents can do or what we should be thinking about more broadly to address this problem? I know that's a big question, but I'm sure you have thought about it.
Yeah, I'd be curious what your thoughts are on it. Certainly in terms of primary prevention, I do really think that, making sure teens feel connected and safe in their worlds and in their social networks, having a place in the world and having a sense of self in the world is really like fundamentally builds, kind of mental well-being. And that's true for adults and kids across the board. And so, obviously the mental health workforce is a situation that we need to improve. But as we're doing that, ensuring that, we're finding ways for kids and teens and young adults to build connections and communities that are, sometimes outside of these formal sort of religious affiliations, which have historically been a big part of filling that gap, I think is really important.
Yeah, no, I think the other thing you mentioned towards the end, which I've been thinking about is, how economic policies or policies that buffer economic strains on families, how they may ultimately improve or buffer adolescent mental health. If you can reduce, people don't know, if families have, and we saw, for example, increase in certain problems with the Great Recession. And if you can, there's been some interesting work on that, but buffer from adverse economic consequences, and that, at least maybe one thing we can do. We don't always think about economic policy.
Absolutely. And, I didn't talk about, but we've been doing other work related to, social safety nets and economic factors, right, and how fundamentally that has changed adolescent life, as well as we've seen, rising income inequality. It really, it's always so shocking to me, especially in recent weeks and months, to hear people, when they're talking about COVID policies, saying that, kids need to return to the joys of childhood. And I'm like, which kids are you talking about? There has, like, not only have mental health problems been growing, but there was like extreme fracturing of the social safety net well before that. So it just seems to me like a very curious statement to make, because I don't think that the way we were building resilience for kids' mental health was working in any capacity. Right. So I think you're absolutely right that, it's going to require both a policy effort as well as like community-based effort and a mental health workforce effort.
Right. Yeah, I think all those things. And the other thing that I found I hadn't seen that specification analysis, but I also liked your analysis of how adolescents spent time, because that is something that has struck me very much, is the amount of unstructured, even as a hardworking, good student, involved adolescent, how much time I spent driving around in the car and hanging out at the mall, and it's in, that those shifts capture how many changes there have been in adolescents' lives beyond phones, et cetera. Okay, let me get back to some questions. There's been some, so there were some questions about the religious sort of attendance or religious involvement and depression. And some people asked about, could it be, is it actually the religious attendance, or could it be family cohesiveness, that there's been changes in, that's sort of, I guess, an indicator of changes in families doing something together. Sort of what's going on there. Yeah, that sort of, there were broad questions about that. And then also there was a question about, isn't it true that suicide rates among Mormon youth are lower than that among non-Mormon youth? Anyway.
I don't know about that latter question.
Yeah.
It certainly could be. I just don't know that
Yeah.
data. We're working right now on additional analyses of parental monitoring and parental warmth and affection, and how how those trends are changing over time, and they're not changing to the extent that religious service and affiliate. That's not to say that I mean, I think that's a totally viable hypothesis. I mean, part of being in a religious community is that, kind of family and involvement in the religious practice. So, that certainly could be one sort of mediator of that overall trend. Although when we've looked at, we have a bunch of variables on parental monitoring and monitoring the future, and there really haven't been many changes over time, which is kind of surprising. But
right, that is interesting. Yeah, that's interesting. That's the nice thing about data. This was Becca asked a question. In terms of the political affiliation and depression symptoms, is there any sense if mismatch between family or parents and female political identification is a driver of mental health problems? I think it's an interesting question. I saw with some of my students during COVID, like being sent home, some issues that arose were differences that maybe they came out and hadn't told their parents, or differences that emerged between them and their parents, and then being sort of back home as a stressor. But anyway, I was just curious if there's.
Yeah, I think that's a really great point. And I don't know, we don't have data on sort of the family political affiliation. I will say, kind of going back to the religious involvement paper, another part of that paper that I didn't talk about today was we did look at mismatch between religious service attendance and centrality of religion. And the biggest risk factors for high depressive symptoms were kids who attended religious services a lot and did not find religion meaningful in their lives.
That's interesting.
And in our discussion section, we sort of speculated that especially for marginalized kids who might be rejected by the kind of religious community and who are in religious families, that is particularly destabilizing in terms of, again, your sense of self, your sense of connection, and the exposures you might have in the home. So that we were able to look at that on sort of in the religion paper, but we haven't been able to look at that in terms of political affiliation.
Right. That's really okay. That's really, but I'm glad you brought up the religious, how you looked at in that paper. Just a comment I want to read. On the other end, if parents, teens seek treatment, there's such a dearth of psychiatrists taking new patients. Suffering kids can't get treatment. It's a huge problem for people like me, a licensed therapist. When it's impossible to refer kids for treatment, then we just watch the crisis unfold.
Yeah. And anecdotally, I hear that all the time. I mean, I think like you, people reach out to me a lot and they say, I have a teen who attempted suicide and they're in the hospital and we can't find continuity of care for when they're going to be released. What should we do? And it's a really tough situation.
Yes, it is a really tough situation. Well, just to close, is there anything, I guess, any last words you'd like to say as both as a scientist and, scientist, epidemiologist, and a parent with an emerging adolescent?
No, I just would say that, I think that a bigger issue in terms of the research workforce is just having people who are interested in this topic and who want to do the work. And so if people are interested in this topic or anything that I talked about, monitoring the future data is totally publicly available. YRBS data are totally publicly available. There are like 17,000 dissertations that are waiting to be written from these studies. And so if people are interested in this work, I would just really encourage you, and anything that I can do would also note that Columbia has a psychiatric epidemiology training program. So anyone who wants to do additional training in psychiatric epidemiology, let me know. I'm available.
Yes, and I agree. I think this is such an important area, but also an important area that has a lot of room for creativity and new ideas, and for younger people coming in, because as you said, we need to listen to adolescents and understand. That's one thing I have learned as a mom of an adolescent is I need to listen more and understand their experience rather than imposing my, older views all the time. So thank you. And Carrie is amazing. She's an amazing mentor. So as much as I want to keep everyone at Harvard, I would encourage people to check out the Columbia Psychiatric Epidemiology Training Program, which
we have a proud graduate right here.
I am a product of it too. So I have very strong affection for it. So thank you so much, Carrie. This was great. And everyone, we will have this posted online in about a week once we get it captioned, and we will have you back because we could have kept talking. So thank you so much. Take care, and let's hope to see you in person soon.